Right. Section 11, common chronic illness and disability. Describe the clinical features of chronic medical conditions seen in children with the following. Asthma. Clinical features: cough, cough with exercise, cough at night. That's going to be your main clinical feature with asthma. Of course, shortness of breath, wheezing, all of those things factor in as well. But cough is the big thing. Cough at night, cough with activity. There are, let's see, are we going to talk about categories of asthma later? Let me check. All right, looks like this is where we need to talk about asthma. So, how is asthma classified? Go ahead and review that. Pause. How is asthma classified? Intermittent or persistent. So you have mild intermittent asthma, you have mild, moderate, or severe persistent asthma. Sorry, my kids are playing. Mild asthma is going to be symptoms, cough, or albuterol inhaler use less than twice a week. And look, my son brought me a crown. Cough at night, less than 2 times a month. Then you move on to the persistent, which of course are going to be increasing frequency of symptoms, increasing frequency of albuterol use, or very severe symptoms requiring hospitalization, intubation, those kinds of things. It does not say to discuss management, but let's go ahead and do that. So with mild intermittent, your management is going to be a short-acting beta agonist, primarily just albuterol. Okay, as I was saying, short-acting albuterol. Your persistent asthma, you're going to use a stepwise fashion to treat that, depending on what your classification is. So you may choose to add a inhaled corticosteroid at a low, medium, or higher dose. You may choose to add something like Singulair or Montelukast, which is a leukotriene receptor antagonist. Another option would be a LABA, or long-acting beta agonist, particularly if they're a moderate or severe persistent. But remember, we tackle that in a stepwise up or stepwise down fashion, making modifications as we need to. If a child comes in an acute, my doggies make me smile. My child comes in an acute asthma exacerbation, then you're going to use breathing treatments and oral steroids to help get their asthma under better control. In the office or ER setting, you can use inhaled Atrovent to help pop those lungs open. Atrovent is ipratropium bromide to help get those airways open. A total of 3 treatments has been shown to reduce hospital admission. So we use that in the office or ER setting, but we do not prescribe that for outpatient use in the pediatric population. I know sometimes they do that in the adult world. Let's see. I believe we've covered asthma. Cough at night, cough with exercise, albuterol inhaler use are important features in assessing asthma severity. All right, let's talk about eczema or atopic dermatitis. You know, asthma, eczema, and allergic rhinitis, those things all kind of run together. The atopic march, right? They get the eczema, they get the allergies, they get the asthma. Those things tend to cluster together in the atopic child. So atopic dermatitis is the skin rash. It's itchy, it's scaly, it can be red, it has irregular borders. In babies, it tends to be on their cheeks, in their elbows, in their antecubical fossas, and their popliteal fossas, also on their ankles. In older kids, it can be in other places, but that's where we most commonly see it in infantile eczema in the beginning. It can get super infected. You need to make sure you're monitoring for that. Treatment for atopic dermatitis is to moisturize the skin. We use a lot of coconut oil. Coconut oil is magic. We put coconut oil. Georgie still has dog food left. It's fantastic. So for atopic dermatitis, we moisturize with coconut oil. And we can use topical steroids in the worst areas. Now remember that babies' skin surface area is a lot larger than that of adults. So we really want to limit their steroid exposure as much as possible because they're really going to absorb that systemically. So we really want to try to avoid that as much as we can. We want parents to use gentle lotions and soaps and avoid exposure to known irritants, contact irritants. So we encourage like the Dove White or Dove Sensitive soap, moisturizing with Aveeno products for eczema, Aquaphor, Eucerin, or similar products. There are some newer therapies for atopic dermatitis that have limited research behind them at this point. There are non-steroidal options. Some of these use ceramides, which is a missing component of the skin layer, but I expect more evidence to emerge on these over the next several years. Alrighty, let's talk about cerebral palsy. Cerebral palsy is more common in preterm infants. Remember, there's a lot of different types. It can affect just the lower extremities. It can affect all of the extremities, or it can affect just one side of the body. It can be just affect motor skills, or it can have a global effect. It can be as simple as toe walking. Tight heel cords can be the only side of cerebral palsy, but more common in preterm infants and can vary in clinical presentation. Cystic fibrosis screened on the newborn screening. There are also genetic tests for this, sweat test. Cystic fibrosis, chronic lung disease, infertility in males. They need supplementing with various vitamins because they have trouble absorbing them, as well as pancreatic enzymes. Remember the things that can be associated in the neonatal period with cystic fibrosis: meconium ileus, meconium plug. Those are important to remember as well. Next up, we have diabetes mellitus. Type 1's typical onset is in childhood. That is your autoimmune form. We can see several different types of antibodies associated with that, many of which we can test for, which is pretty cool that we can test for that. Typically presents with polydipsia, polyuria, vomiting, dehydration. I've seen attentive parents pick it up first couple of days of illness. I've seen it go for months with lots of weight loss. My husband is so silly. With marked weight loss and kids with marked elevated sugars and bicarbs of 6, which is scary, but I've seen it. We also unfortunately see obesity-related diabetes mellitus, 11, 12, 13, 14-year-olds with insulin resistance. Scary, but we got to screen for it, and we got to address it, and we got to treat it, and we got to try to prevent it. Preventative medicine, that's where pediatrics is at, man. That's what our job is. That's where the fun is, preventative medicine. Features of diabetes: lifelong illness. Make sure you're addressing the psychosocial features. We manage it with insulin. We got 6-year-olds on insulin pumps. They rock it. They pull their little pump out and put their chocolate cake in, and they go eat their cake. It's fantastic what they can do with those pumps and how tightly they can manage their blood sugar. So I'm certainly very thankful that they have those. Complications: hypoglycemia, DKA with our type 1s. And then, of course, the adulthood, renal, non-compliant, ulcers, retinopathy, etc., adult stuff that you can see. Obesity. They say if you don't impact a child's weight by 4 to 5 years of age, they'll be obese their whole lives, unfortunately, unless they self-motivate to make a change. We really try hard in those young years. Now, I'm not going to tell a 9-month-old's parents that the 9-month-old is obese and needs to lose weight, but starting at birth, we start talking about healthy food habits. They start making those first food choices at 4 to 6 months when they introduce solid foods. One new food every couple of days. We start talking about using fresh, healthy things that they've thrown in their food processor without added sugars or chemicals. We want them not to be feeding cheese puffs at 1 year of age. They need to be eating fresh whole foods, fresh fruits and vegetables. Don't be a made-to-order chef. No juice, for crying out loud. It's sugar and colored butter. Please don't feed your kid juice. It's bad. Juice is bad. We need it gone. No juice. No soda, no sweets. A treat every now and then, a soda at a birthday party, or when you have pizza one day a week, is fine, but we can't have it every day. No treats every day. And no treats as rewards. It's not healthy. It's certainly chronic medical condition. You know what complications come from that. We've already covered it. Seasonal allergies, again, that allergic march. We got all kinds of allergies down here in Alabama. And whatever clinical sites you're at, you're going to see that too. Runny nose, allergic conjunctivitis. We're going to treat that with oral antihistamines, topical nasal sprays, and then of course there's the new topical antihistamines for the nose and for the eyes. HIV and AIDS. HIV can be maternally transmitted. I do see that occasionally. Unfortunately, we do try to reduce the risk of maternal transmission. And those kids can have a pretty rough course early in their life, unfortunately. We do see teenagers acquire HIV through risk-taking behaviors as well, making sure that we're aware that that's a possibility and that we're testing for it through appropriate screening as per the CDC guidelines for STD screening. So make sure you brush up on those. Sensory impairment, this usually presents in the younger kids. Now, every kid's got something they're funny about. They don't like the way their socks fit, or they can't stand to have bumps in their hair, which clearly doesn't bother me. Every kid's got something they're funny about. So, but knowing when that line is crossed and when you need to refer for sensory therapies or for further evaluation. Describe how chronic illness can influence a child's growth and development, educational achievement, and psychosocial function. Well, of course, it can impact every single aspect of their life, and that's why we as pediatricians have to be aware of that, and we have to ask questions about every single aspect of the child's life. How's school going? Are they able to go to school? Are they able to function in a classroom environment? How's their asthma? Is the mold in the school that was built in 1965 a problem for their asthma? Do we need to modify what we're doing to make their asthma under better control so they can be better functioning at school? We need to ask these questions and make sure that we're addressing appropriately their issues so that they can be successful and grow and develop in every realm of their life. It's really important. All right, that concludes this section.